Just a few things before we get started in terms of housekeeping. The event will be recorded, so that it means you're able to catch up, and those people unable to attend today can watch this recording at a later time. We're happy for you to have cameras off. Appreciate it's 1 o'clock. Some of you may be eating your lunch, so happy for cameras to be off. If you don't want to appear in the recording as well, then please, happy for your camera to be switched off. We will keep participants muted just so that we can reduce some of that background noise, because we know that Teams for some reason lets everybody into a group meeting unmuted. So we will mute you for clarity. There will be an opportunity to ask questions during the session, and please put any questions that you have in the chat. So without further ado, today's session on frailty and type 2 diabetes, practical tips for management, is going to be delivered by two specialists in this subject. So Louise and Kiszy, I'll hand over to you to get started on today's session.
Thanks very much, Mary. So hi everyone, my name is Louise. I'm the diabetes lead for the medicines optimization team at the ICB. And I'll pass over to Kiszy to introduce herself.
Hi, and I'm Kiszy Locke. I'm a diabetes specialist nurse, and I'm the clinical lead for the diabetes pathway in Sirona.
Thanks, Kiszy. So I'm going to share my slides, which will be shared after the event, as well as Mary's already said. And as Mary has introduced, the aim of this session is just to provide some practical tips about managing frail patients with type 2 diabetes. And this has been generated as a result of the launch of the BNSSG frailty guidelines for type 2 diabetes, which you can find on Remedy. And the aim is really that we're going to provide an overview today of considerations when managing diabetes in those frail patients, so just type 2 diabetes, through practical application of those guidelines that you'll find on Remedy. So let's just start with a bit of background. Diabetes and frailty presents a huge challenge in our ageing population. We know worldwide that the prevalence of diabetes is increasing, and more than half of our population with diabetes are aged over 65. We also know that diabetes seems to accelerate the emergence of frailty, and frailty is 3 to 5 times more prevalent in people living with diabetes. Frailty is therefore becoming an emerging new complication of diabetes and has significant impact in terms of increased adverse outcomes and reduced survival rates for those patients. And in combination, frailty and diabetes negatively impact mortality, psychosocial well-being, and quality of life. And as a result of this, in turn, causes significant challenges and demands on health service provision. So this diagram provides an overview of the shared pathophysiology and differential outcomes of diabetes and frailty. So the circle in the middle shows the shared pathophysiology between diabetes and frailty. What we find in frail older patients is sarcopenia. So sarcopenia, as many of you know, is an increased loss of muscle mass associated with aging, which results in functional decline and is associated with increased morbidity and mortality. In patients with sarcopenic obesity, what we see is an increased loss of muscle mass, but also an increase in visceral fat, which in turn leads to increasing insulin resistance, which, as we all know, is associated with type 2 diabetes, but also often associated with frailty. Age-related changes in cell function, hormone and metabolic changes, reduced testosterone levels, for example, reduced protein synthesis, all contribute to these the impact of these conditions. And we all know that underlying low levels of oxidative stress and chronic inflammation are important in the development of frailty and diabetes. The arrows on the sides of the chart demonstrate the bidirectional relationship between frailty and diabetes. We talked about a lot of this on the previous slide, but we see diabetes is linked with an increased incidence of frailty. It's a predictor for someone moving into those higher levels of frailty status. And we know that frailty is an independent risk factor for morbidity and mortality in patients with type 2 diabetes. And also we tend to see more diabetes in those older, over 65-year-old patients. So awareness of these two conditions and their interactivity really is becoming more and more prominent as an important consideration in guideline development and national consensus. And this is because we know that people with frailty have increased risk of adverse effects from treatments for diabetes. So, for example, an increased likelihood of hypoglycemia due to lack of sensory awareness, and also an enhanced vulnerability to the consequences of those side effects, such as falls, fractures, and hospitalization. They also often have other associated comorbidities, such as heart failure, which may render treatment contraindicated, or chronic kidney disease, which may necessitate dose adjustments of therapies. We also know that these patients are less likely to benefit from those long-term protective effects of tight glycaemic control, and there's therefore an important element of review is to get a balance between the two, adopting individualized care, taking into account that patient's preferences, comorbidities, risks from polypharmacy, and their likelihood of benefiting from long-term intervention. So an essential component of diabetes review is therefore frailty assessment. So hopefully you'll all be familiar with this. This is the Rockwood scale. This is included in the frailty guidelines. And if you're unfamiliar, I'd encourage you to look at the guideline because there's a top tips link in there on how you can use these clinical frailty scores in practice. But the key thing to remember is that frailty is a dynamic process and it can change, and it's therefore important to reassess that level of frailty at each review, and also as a result of any change in health status of that patient. So we're now going to go on to our first case study and hopefully guide you as to how you can use the guidelines to set targets for patients, think about recommended interventions and treatment goals for those patients. So I'll pass over to Kiszy.
Thanks, Lou. Okay, so just thinking about this first case study. So this is often a kind of search we do with practices in virtual clinics where we're looking at treatment targets and thinking, oh, we'll do a search where a group of patients are just missing on, you know, are low on one of their treatment targets. So the other two are fine. So this one, blood pressure and cholesterol is great. It's just the HbA1c is above target. So it's just a helicopter view on, right, not hitting 3 treatment targets. Let's just have a quick look. So we just looked at the diabetes medication. So we've got Janet, who's 55-year-old female who's got type 2 diabetes. Her current medications is metformin, modified release, and she's on 2 grams once a day. And she's on DAPA, 10 milligrams once a day, glycoside, 80 milligrams BD, and Humulin I, which is 26 units in the morning and 16 units in the evening. And her HbA1c is 68, total cholesterol 3.6, non-HDL 1.8, BMI 38, blood pressure 122 over 70. So just looking at that, thinking, right, can we just increase her insulin a bit just to get her HbA1c down and see if we can get all 3 of those in target. So just looking at that, and we want this to be a bit of an interactive case study. So on the next slide, we have a, if you can all follow this with your QR codes and do this Mente. So we're just about to ask you this question. So just thinking about that, what other information do you need to know about this lady? Oh, here we go. Takes a while to come through. I was thinking, oh, everybody switched their cameras off and gone now. They're just waiting for the recording. great. So yeah, thinking about lifestyle, what other comorbidities has she got? What are her blood glucose? What actual readings have we got? Social situation, mobility, frailty. Yeah, great. Anything else?
Kiszy, we've got a comment in the chat from
Yeah.
Magda. Is it safe for her to be on glycoside and insulin at the same time?
Yeah, is it? Yeah, that's something that we could think about as well. Wait, Magda, we got another question for you in a bit when we got a bit more information.
You're one step ahead.
You're one step ahead. Yeah, brilliant. Okay, so let's have a look at the next slide then. So now we've got a bit more information. So we're looking at all of her medications. And now we can see actually she's got quite a lot of medications, and quite a lot of these are cardiovascular meds, aren't they? So what else has this lady got going on? Also looking at those blood results, they were taken 2 months ago. So actually that's kind of past, isn't it? And what is the actual picture at the moment? Other bloods that were taken was just showing EGFR or ACR, albumin. And actually we've got some blood glucose levels reported by the INT, because they do BD visits. So now we're actually finding a bit more out about the social situation, what's going on at home. So blood sugar's 4 to 8 there, past medical history. So she's got quite a bit, hasn't she, of history there, other comorbidities. So let's osteomyelitis, and she's had an amputation there in the past. She's had stroke, she's got heart failure, hypertension, retinopathy. Somebody was saying about what about her eyes. She's also got a catheter, and she's got an active sacral sore as well. So actually, from our first review, this is quite different, isn't it? Just looking at like that helicopter view and just looking at the diabetes. Now we've looked at all these other things. Social history as well. So she lives alone with a BD package of care to support with some of her ADLs. She's had a recent referral to the district nurses for BD insulin administration support, as there was some memory issues. So now you know this, we've got a bit more information about her. What would be your concerns? Magda, you can put this in there now about your glycoside and your Humulin I. Is it working? Yay. Yeah, so memory issues, compliance with medication, yeah. Falls on SU and insulin, social care, memory issues, risk of hypos and falls. She's on 2 medications there, isn't she, that can lower blood glucose levels, causing hypos. Polypharmacy, yeah, she's on quite a lot. Self-care, yeah, what can this lady actually do for herself if she's got BD carers? What do they actually do? Yeah. Anything else? Yeah, I think the main concern is she's on a lot of medications there, isn't she, for someone who's quite reliant on carers by the looks of it. Okay, let's go on to the next slide then. So let's have a look. So just thinking about Janet, although she's 55 and quite young, she has got quite a lot of comorbidities, hasn't she? And just thinking level of dependence on carers, I think we need to find out a bit more information about what can Janet do for herself. Is there any other people that support? Is there any family or close friends that come by that might do some shopping or other things for her, sit with her for a few hours daily? Or, you know, is there anything else there to support her? Is there adequate food in the house and treatment for hypos? Are the carers aware of her diabetes and what their level of knowledge is around her medication and food requirements? Because she's on oral medications, they might prompt with that. And also, what type of food are they aware about carbs, needing carbs in her meals if she's on insulin? So it's finding out a bit more information from them. So she's got an open wound on her sacrum leading to decreased mobility and bedbound at present. to relieve pressure on her wound. So if she's bedbound, is Janet able to treat a hypo if one occurred when the carers weren't present or overnight? And also just thinking about dietary intake and that kind of environment for optimal wound healing as well. So memory concerns, is there any underlying cause? Is this a sudden onset of dementia, or she need bloods to check any other, if she's got any, low in vitamins, those kind of things, to see what's going on there. And could this memory concerns, could this affect Janet's ability to recognize a hypo? Is she aware when her blood sugar's low, less than 4? Does she get those kind of early warning signs? And does she remember to eat at lunch if there's no carer there? What do they do for lunch? Do they leave her a sandwich that she can help herself to in between their visits? What kind of routine does she have for food? Or does she overeat? Does she forget? And she's got loads of snacks around her that she could help herself to. So it's just finding out a bit more of what happens on a routine day-to-day basis at home for her. Blood glucose levels, so it said 4 to 8 reported by the district nurses, and if they're going twice a day, then we've got that morning reading, and we've got a one later on in late afternoon, early evening. Those levels don't represent that HbA1c back in December of 68. It would be much lower. If they were literally 4 to 8, it would be around 38. It's probably better than my HbA1c, and I don't have diabetes. So it's kind of thinking, oh, is things got a bit tighter now that the INT are involved and they're giving the insulin for this lady. So actually, what range has she got on that insulin PSD, and is it too tight now we know all this information about this lady? So looking at that scoring, I've kind of scored her as a 7, which is quite frail, isn't it, when you look on that score earlier? So thinking about her, is this all a bit too tight? Is this regime, all these drugs, are they all still appropriate now we've assessed this situation? So looking at her diabetes medication, she's on 2 therapies that could cause hypo, so she's on glycoside and insulin. And just as Magda said, are they both required? So something to address there. Does she need both of these on her list? Okay, so let's have a look at the next slide. So trying to apply the guidance that we've got. So target setting. So if she's a Frailty Rockwood score of 7, it means she's got significant comorbidities and functional deficits and limited independence. And she's got a markedly reduced life expectancy. So it's thinking actually in the next 10 years, is, all those kind of risks that she could get if her blood sugars were really not well controlled. So just thinking long term, trying to weigh out the benefits here. So treatment goals for her would be to promote optimal wound healing. So although we don't want blood sugars too tight, we also don't want them really high, because she's got this open wound and we'd like to try and promote the wound healing there. Because if we can get her back out of her bed and back into a chair, it's a bit more independence for her as well, if she can get around in a wheelchair by herself. So a treatment goal is symptom control as well, not to make sure she's not having frequent hypos or hypers that would cause issues. A main theme would be avoiding hypos with this lady, because we don't think, she's quite restricted to what she can do if she's bedbound at the moment, and unlikely to be able to self-treat, especially if she's not recognising symptoms of hypos as well. So we'd want to avoid hospital admission. She's still for active treatment and she's not end of life at this stage, and would want to control her symptoms but avoid metabolic emergencies as well, such as the hypos or HHS if she was significantly high for long periods of time. So recommended targets, so HbA1c of 58 to 70, but up to 75 could be acceptable. Fasting blood glucose levels would be 6 to 12, but up to 13 may be acceptable, and blood pressure being less than 150/90 with no postural drop. So recommended interventions for this lady. So liaising with the patient and next of kin carers and the community nurses, just to get that more information that you need really to support this diabetes review. Assessing Janet's knowledge and understanding of her diabetes management. Has this been affected by her recent memory issues? As this will support your decision for making some changes. If she's really not aware and she's losing that awareness, you know, we really need to kind of relax the targets a bit and blood sugar levels a bit. So less aggressive glycemic targets to avoid hypos, but be aware that hyperglycemia can increase the risk of infections, and Janet has an open sacral wound, so we don't want her going too high. CGM, could this help support the review of her glycemic control and titration of medications? So she would fit the criteria as she's on insulin and she's requiring third-party support for the administration, and consider stopping glycoside and reducing the insulin. Review of dietary intake, assessment of weight loss, and is she meeting her nutritional requirements to support wound healing? Is she getting enough protein in her diet? You know, all those kind of things. And recent change in bedbound status, could she have some exercises while she's still in the bed just to encourage that muscle strength and reduce further decline? Because if we can keep that muscle strength up, it could be that we could get her back out in the chair, couldn't we, once her wound is healed? Has other medications been reviewed recently, and could this be discussed with others to see if this can be simplified? Because she's on quite a lot of medications there, isn't she, for cardiovascular issues, heart failure, and she's had a stroke in the past. But have they been reviewed since she's had this recent decline? So the plan and ongoing review for Janet. So what we did was we had a discussion with Janet and other healthcare professionals. She's not always aware of hypos and lacks knowledge and retention of hypo management. Carers were supported to ensure correct items in-house for hypo treatment and a good nutritional balance of her food to support wound healing. Also liaised with therapists just to get some ideas around some exercises to try and keep her muscle strength up. As we talked about earlier, with her hopefully getting her back out into the chair. And due to the above, the diabetes medication was reviewed, metformin was continued, the glycoside was stopped, CGM was applied and enabled a decision for the BD-Humulin I to be switched to once-a-day basal. Her SGLT2 was being used for management of heart failure rather than diabetes control, so asked others for review really of her medications. Oh, there you go. Sorry. Request to heart failure team and GP to review all her other meds to see if still appropriate due to the change in her overall health. Ongoing input from the district nurses for third-party insulin support with CGM sensor changes as well, and visits were reduced from BD to once a day. Lovely.
So as you can see from that case study, polypharmacy is a big issue in patients with diabetes, given their other comorbidities and treatments associated with those. But actually, from a frailty perspective, de-prescribing can play a really important role. And the aims of de-prescribing are to reduce over-treatment, treatment burden, and risk of harm as part of a supervised process. And there are 5 key parts that can be played within this. So firstly, we have stopping. That might be stopping a medication completely or reducing the dose. And it's important to reflect that in diabetes management, this can be related to glucose levels, blood pressure, or cholesterol. It might involve switching to an alternative glucose lowering class with a more favourable risk-benefit ratio. Or an example would be in a patient with new onset heart failure who's on pioglitazone, you might want to look at stopping or switching that to an alternative because of the contraindications. Or it might be switching to alternative glucose lowering therapy that has a lower risk of hypoglycemia. It might be about simplifying the regime, as was the case for Janet, going down, removing the glycoside, going down to once daily insulin, or other elements within that regime. It can also be about reducing the need for monitoring and assessment. So does that person have the capability of self-monitoring their blood glucose levels? Is there an intervention such as CGM that could be employed there, or actually could medication alteration remove that need altogether? And then really, really important is that safety netting, particularly with insulin, but in fact, when stopping any or changing any elements of that regime, making sure there's a clear plan for how you're going to follow up that patient, liaising with the patient and or their carers or the community nursing team if they're involved, about how and when they can contact you or another person for advice about their patient if they've got any concerns. There's a lot of information about de-prescribing in the guideline that I'm going to signpost you back to. But we're also now going to go through our second case study just as a further example of this.
Okay, so case study 2 then, we're looking at Derek, who's an 80-year-old male with type 2 diabetes, and his current diabetes medications are metformin, modified release 1 gram BD, and he's on Humulin M3, 20 units in the morning and 12 units in the evening. And his HbA1c has come back at 126, eGFR 66, total cholesterol 6, non-HDL 3, blood pressure is high as well, 162/90, and BMI of 28. So just looking at top level kind of review of him with his diabetes, when we look at the free treatment targets, all of these are above target, aren't they? But it's just looking, what other information do we need to find out about this gentleman? So again, if you could all have a go at putting in your thoughts. Yay. Okay. Good. So we've got some coming through. So looking at his social circumstances, his understanding. Is he taking his medications yet? Because all his blood seemed to be up, not just one, isn't it? So actually compliance, what's going on there? What other comorbidities has he got? Is there been a sudden change since his last annual review? Because that's quite, what was his past HbA1c? Has he always been high, or is this a drastic decline? What's gone on there? When did we get the results? Medication, is it insufficient? Yeah, who's doing the medication? Is it him, or does he have any support? Yeah, great. Okay, so now we have a bit more information. So when we look at his other meds, so he's not on too much medication, but he is on a statin. So he is on medication for treating his cholesterol, and he's on ramipril as well, so blood pressure. He's on an inhaler. So these were taken 2 weeks ago, so they're quite recent, these blood results. So a bit of history. So did not attend his last retinal screening. Previous HbA1cs have been 55 to 60, so that's a bit concerning, isn't it? It's quite an increase there. Previous cholesterol was lower, blood pressure was lower as well, and his BMI was a bit up as well before. So we've got a bit more information there. Again, past medical history. So he's got COPD, hypertension, type 2 since 2000, went on to insulin in 2010. Okay, so that makes me think it's type 2, not type 1, and we haven't got the wrong diagnosis, so that's good. Usually fit and well. Last attended surgery a year ago for his annual review. But when we look further, actually, social history is recently widowed, no next of kin, but close neighbour who's also raised some concerns. So what would be your concerns about this gentleman? If you could input your responses again, that'd be great. Yeah, so is he not taking any of his medications? What other bloods do we need to do? A bit of self-neglect, yeah. His mental health, what's going on there? Memory, Is he not eating, not taking medications? Yeah, risk of hospitalization with those levels going up. Yeah, low mood. Yeah. Brilliant. Yeah. Next slide. So let's have a look at the concerns then to address for Derek. So sudden decline in HbA1c. So I would be thinking, what is the cause here? Have we got any red flags? So he's got some weight loss, but actually, is that intentional? Is there a well-known reason for that? So that would be something to kind of investigate there. Recently widowed, so I think we need to find out what support did his wife provide. Did she actually, you know, prompt him with his meds, dial up his insulin? What did she actually do? And has this impacted on his ability to kind of self-manage? Any social isolation, so any other support, concerns from the neighbour, so getting a good conversation with that neighbour would be good to find out what kind of issues there are, if there is any other next of kin or close friends at all. So he's got a decline in all 3 treatment targets, hasn't he? It was his blood pressure, cholesterol, as well as his insulin. So makes me think, has he not taken any of his medication? Because all 3 have gone out, haven't they, quite a bit. So if he isn't taking his medication, why? What's happened there? What could be the cause? Is it memory? Is it capacity? Is it dexterity with the insulin or getting the pills out of the boxes? You know, did his wife do this for him? Is it his sight? And also, you know, is there some depression and self-neglect since his wife has died? So applying the guidance in practice then, so let's look at target setting for him. So on the Frailty Rockwood score, kind of 4 or 5. I think we need to find out a bit more information really of what's going on at home to definitely say what we think it is. So recent deterioration since his wife has died, unsure how he is managing at home. Neighbour has some concerns that he's not looking after himself and often supports with a small food shop. So thinking about what kind of food is he eating? Does he actually eat it? Usually independent, but a possibility of some impairment in activities of daily living. Further assessments required. Could aim for mild frailty as glucose levels very high at present, and you know we wouldn't want to reduce them too quickly that we cause other problems with hypos and falls. So gradually kind of thinking about bringing him down. Treatment goals, so is to limit the progression of microvascular complications, control of symptoms and avoid metabolic emergencies such as hypo and HHS, because although he's 80, previously to this he was quite fit and well really, wasn't he? And he could live for all we know into his 90s, but we need to do a bit more of assessing in bloods and things just to see what's going on. So recommended targets, so HbA1c between 58 and 64, fasting blood glucose levels between 5 and 8, but up to 11 may be acceptable, and a blood pressure of less than 140/90 with no postural drop. So recommended interventions then for this gentleman. So liaise with Derek's neighbour to find out exact concerns he has and what support he provides for Derek. Face-to-face appointment to assess this condition to include physical examinations, because are there further symptoms or concerns that would need further investigation, tests or imaging, you know, to rule anything underlying out. Gain actual blood glucose levels and ketone level because it's so high and he's not been seen for a while, just to rule out any problems there. Do a news score as well, an infection screen, just to see, you know, actually, is he well enough to stay at home in this situation or does he need to be seen more acutely? Assessment of memory and emotional well-being to see if this has impacted his ability to self-care. He could potentially have some resistant exercise and nutritional interventions to reduce risk of further deterioration. And not to restrict his diet if he's low weight or losing weight. Does he require some nutritional support? So thinking about food first approach if we've assessed him. And social prescribing as well to reduce social isolation and increase his well-being. So plan an ongoing review Derek. So discuss with Derek's neighbour. Neighbour has concerns of self-neglect since Derek's wife has died, feels he's struggling with grief and very depressed. Due to this, has not really looked after himself. He's got reduced appetite, not eating much. And this could be the likely cause of his weight loss. We've got clear signs there, haven't we, that his appetite has changed and a reason for it. Review of Derek's glucose levels 22, no other glucose readings as he wasn't testing at home. His ketone level was normal and there was no further weight loss. And news was stable. No other symptoms except for general tiredness. Memory screen showed mild impairment and depression screen scored high. EMIS prescriptions checked and not frequently issued, likely not taking medication regularly. On further discussion with Derek, he reports that he got fed up with taking his medications and feeling depressed. His wife used to support with sorting his medications as he would often forget his evening dose, so likely cause of his deterioration in control in his blood pressure, lipids and glucose as he's not taking them regular for some time now. Wife used to do all the cooking. Derek not cooking much at home as feels not worth cooking for one, eating mostly highly processed foods, sugary foods as well, gain consent for social prescribing to support with social interaction with others, keeping Derek active, supporting him with some nutritional advice and well-being support, and his neighbour is still supporting Derek as well with his bits of shopping. So what could you change to simplify his regime to support him to maintain his independence, really? What would you think about doing? Daily insulin? Yeah, could be an option. Oh, look. Everybody's been reading the guidance, Lynn. Social care assessment, yeah. Change insulin regime to once a day or oral maybe. Care package. Support social prescribing, yeah. Daily insulin seems to be a frequent one occurring there, doesn't it? Okay, shall we see what we did? Let's have a little look. What did we do? So discussion with Derek regarding his medications, and we liaised with the community pharmacy for ways to support him taking his medications. So could he be set up with reminders before we automatically went with a Dosset box, but having that assessment on could he open the boxes and get the tablets out and things like that. So that was all being taken care of. Discussed simplifying his insulin regime, so no side issues, previous glucose controlled well when taking his insulin regularly, not large doses, so likely actually could he manage on once a day basal insulin regime alongside metformin. So Derek would find this easier to manage, and discuss delivery device. Derek finds it difficult to change the cartridge at times, so we got him a pre-filled pen as well to help him maintain his independence. So insulin regime was changed to Basaglar 24 units in the morning to support simplifying his regime and increasing his adherence and maintaining his independence. Close monitoring at initial change, then reduced to once a day BG levels in the morning, followed up by 3 months blood test after being back on all his medications regularly, and he had improvements in all 3 treatment targets. So ongoing review of memory and well-being, both have improved with reduction in glucose levels and social prescribing, which has supported routine and independence. Derek and frequently attends a gym with the Aging Well group, so it was quite a positive outcome. Okay, so just thinking of some tips really for trying to simplify an insulin regime. So just thinking about optimizing insulin delivery methods. So insulin pens with memory functions to help track doses. So if we've got people that kind of need reminders, actually, is there a pen that could support that? Or could we use phones or alarms, to help them avoid missing the doses? Doing an assessment of their sight. I know we've lost out now on the Innolet devices, which helped quite a few people to maintain their independence, but actually could a magnifying glass help them to see their dose and they can dial it correctly, but still keeping them independent rather than relying on somebody else to get their insulin? Assessment of dexterity as well. So is a pre-filled device more suitable to, are they finding cartridges really difficult to put into a pre-filled pen? A cartridge and pen. Is having multiple daily injections causing burnout of their regime? Is it causing them distress? So could a rapid short insulin just be used for the main meal rather than all the meals? Or is having two different insulins too confusing? Could this be changed to a mixed insulin? Or do they require the bolus element of the regime at all? Could this just go down to once a day? Long acting. Does the patient find it difficult to adjust insulin doses, and would a fixed dose support them to simplify things at meal times? Or would an ultra long acting insulin allow for more flexibility of time of giving the insulin? Could they be, if you've got somebody that wakes up at 8 or wakes up at 10, and there's quite a few hours difference sometimes in the time that they give it, would that be more suitable? And could we use CGM to ease regime and assist in data and decision making to simplify regimes? So, if they fit the criteria, could we use it to support them in simplifying things? So although we've got this guidance, there are always people that are outside of, it is just guidance, and it's individualized HbA1c targets is obviously the main thing that we should do, really. We have people that we try to get tighter control, and for whatever reason, it's just we're not able to maintain it without making their life, or their circumstances a bit unsafe. So actually knowing when to relax the targets a bit more, and I'm thinking especially when people are palliative or becoming end of life, and actually not really looking at targets too much, and actually we should just be looking at symptom control, and then keeping them out of hospital and keep them in the place where they want to be in these last days, weeks. So just thinking we can use these guides to help us set the HbA1c target if they are higher, if they need to be higher than what is recommended in those frailty guidance. And again, it's just to emphasize, it's looking at the person as an individual.
Thanks, Kiszy. So what we've done on this final slide really is just a bit of a reminder of what to consider at each review in the context of frailty and diabetes. So the importance of that routine assessment of level of frailty, it can change. As was shown with Derek, for example, his memory and so on got better when his blood sugar levels were improved, but someone can also have an acute episode and their frailty can be quite dramatically altered. It's about, as Kissy's just said, that individualization of that HbA1c target and remembering to measure that as indicated. So if there's been a change in therapy 3 months after, and then once therapy is stable, then you can just reduce the frequency of that. It's about remembering always, as is the foundation of diabetes management, advice ongoing about diet, physical activity and weight maintenance. But these conversations might be quite different to someone who is frail than to someone who isn't, in terms of maintaining muscle mass and strengthening activities and not promoting necessarily low-calorie diets. It's always important to check adherence. I can't emphasize this enough, and this isn't just for frailty, this is for everybody. Checking that they are actually taking that medication and that it's being taken as directed. Stopping medications that are not tolerated. It's really important, actually. It helps the patient to engage with their diabetes management, but also reduces their risk of harm from those medications as well, an important consideration. stopping medications that have no impact. So when we start a medication, we will have in our minds, after discussion with that patient, the aims of that treatment and the review that will be undertaken to assess whether that impact has occurred or not. We did a prescribing project as part of last year's prescribing quality scheme, looking at, for example, insulin and sulfonylurea prescribing in patients with a HbA1c of below 53, who are at risk of hypos. And a common theme that comes out is some resistance around stopping medications that have had harm, but also when we did the DPP4 project, medications that have had no impact on HbA1c were still continued, so no benefit to that patient. So it's around that discussion right at the get-go of starting treatment. These are the aims of treatment. This is how we're going to measure it, and this is what may happen if that impact doesn't occur. So it's making sure that that's a joint decision. Now we've got the complexity with diabetes now that SGLT2s, for example, have multiple indications. So you always need to make sure you're absolutely clear how that medication is being prescribed and the indication for that. So an important thing to consider there. Also talking about sick day rules, not just making sure that the patient is able to know what those are, but are they able to follow those sick day rules as their level of frailty increases? And does that therefore make the prescribing of that medication safe to continue? If they can't follow the sick day rules, does there need to be discussion about the safety of continuing that medication longer term? And then thinking about any dose adjustments or maybe cessation of treatment in the development of renal and hepatic impairment. And then just so that you're aware, we've worked with Ardens to get the template updated that you may see in practice for diabetes. And actually there is a prompt now on there asking you to think about frailty status when reviewing HbA1c targets, just as a reminder of the need to individualize those targets based on that level of frailty. So you've obviously got the guideline to look at on remedy, but you might also need a bit of ongoing support. So obviously Sirona have their advice and guidance line. They also offer virtual clinics and that insulin initiation course. Secondary care are available for advice and guidance for patients on their work lists, but not for new referrals. That would be the Sirona you would go to first of all. And then there's lots of valuable information on the Diabetes UK website and the Trend website as well. So that brings us to the end of the presentation today. I don't know if anyone has any questions that they wanted to run through in the final few minutes, but thank you for your time.
Thanks, guys. There was I'm not sure if it's a question or a comment in the chat from Farnaz, who's noted that the new frailty guidelines are quite different compared to previous in terms of suggested HbA1c targets. I guess that's go away and have a look at the new guidelines and understand how those have changed.
Yeah, but it's again, it is just remembering to have that individualized approach as well. These are guidelines which are set on the national guidelines, which were updated, and the previous ones we had were 2017, so quite, long ago. So they have been updated in line with the most recent national ones. But again, it's just remembering that they are guidelines and just to make sure, you can individualize the targets if you need to.
Okay. Farnaz, I see you've got your hand up. Do you want to just come in?
Thanks, Mary. No, I think it is kind of just answered my question. It was just, I think like, for example, on the previous guidelines, it was just the amount of change surprised me. Like on the previous guidelines, we had, no targets or even below 85, I think, for severe frailty. Whereas now for severe frailty, it's sort of anything between 58 to 75. So, yeah.
And that's fine if they're not getting hypos, isn't it? But if they're having frequent hypos, then, we need to relax it still. So it's an aim, isn't it? But actually, if we're going to cause harm for some patients trying to get it to that, then actually relax it further.
Thank you.
Okay, any last questions or comments for Louise and Kiszy? Christina's just asked, can you put the email address up for Sirona again, please, or pop that in the chat? I think it was on your last slide.
I will do, yeah.
Fabulous, thank you very much. So the slides will be available along with the recording and any other materials and links that will be helpful for you. Thank you so much for joining us today. If you could please fill out the feedback form, which is in the chat. Really helpful for us to understand the value of these sessions that we put on at the Training Hub, and so we can make them useful to you for the future. So thanks for joining us. Please fill out the feedback form and look forward to seeing you all again soon.